Welcome to Behavioral Health Today, a podcast brought to you by the Triad Network. This podcast is designed to share trending topics occurring within the world and our communities and bring them a behavioral and mental health perspective.
Welcome to Behavioral Health Today. I'm your host, Sharlee Dixon, and today I'm joined by Ruby Mehta. Ruby is head of behavioral health at Cityblock. With a unique background as a former investment banker turned clinical social worker, Ruby brings strategic and financial expertise to the world of behavioral health care. She has deep experience in clinical strategy, operations, and direct care, and is passionate about making high-quality mental health services accessible and scalable. Ruby thrives in mission-driven organizations, and at Cityblock, she's leading innovative approaches to improve care for individuals with serious mental illness and substance use disorders. We're thrilled to welcome Ruby to discuss how Cityblock's advanced behavioral health program is revolutionizing care for individuals with serious mental illness and substance use disorders by harnessing the power of community health partners, or CHPs, integrating vital social support services, and adopting a value-based financial model to drive better patient outcomes. Ruby, thank you so much for coming to the show. Welcome.
Hi, thank you so much. Happy to be here.
Absolutely. So to get us started today, can you tell us what Cityblock is and what inspired the development of the Advanced Behavioral Health Program?
Yes, absolutely. So Cityblock is an integrated provider, a healthcare provider that provides physical, social, and mental health care to its members. So essentially, when a member is part of Cityblock Care, they get assigned to a care team that includes a physician, a nurse, a social worker, a psychiatrist, a pharmacist. And so, while sometimes it sounds cliche, we really do provide whole person care because we find that social, physical, and mental health care are all so related. And so you were asking about the inception of the Advanced Behavioral Health Program. So part of this started about maybe 3-4 years ago. We were taking a look at our population. So Cityblock manages health care for, call it tens of thousands of folks, right? And we took a look at our population across the board. And we said, what are the driving factors of utilization? What are our members really struggling with? And it quickly emerged that there was a segment of our population that had high behavioral health needs, things like schizophrenia, substance use disorders. In fact, it was, in terms of size, it made up 25% of the population's cost of care, but the size itself was 8 to 10% of the population. So a smaller portion in terms of numbers, but it made up a disproportional piece of the cost and utilization. So essentially we said we have to design an intervention for these members. And so doing a deeper dive into what these members were struggling with, schizophrenia emerged. So a lot of inpatient hospitalizations for things like schizophrenia and psychotic disorders, bipolar disorder, and substance use like alcohol and opiate use. And so those are things that are treatable, right? Some of them are lifelong conditions, but there are very evidence-based interventions for them. It's just a matter of getting those interventions to where they need to be, and speaks to access and, finding the right members. And obviously these members are incredibly marginalized and sometimes their access is really poor. So that's kind of how the program started, by doing an analysis of our population, finding out some of the key drivers of utilization, and then thinking about what are the interventions we could possibly deploy to meet the needs of that population.
Awesome. And like you just mentioned, finding your patients or your members that suffer with these serious mental illnesses can be tough. So how does Cityblock identify and then even engage with those individuals so that they benefit the most from the program?
Yeah, again, great question. So there's a couple of different ways we identify members that we think could be a good fit for the program. I'll go over a few of them. The first one, which I personally found to be most interesting, is we have a lot of information on these members because we work very closely with the health plans, the health insurance plans that these members are part of, and we get claims information. So we have a lot of historical information about their diagnoses, how many hospital visits they had, things like ambulance rides, age. And what we do is we run on our end, we have a pretty robust data science team that runs a machine learning algorithm that takes all the information of these individuals and kind of predicts who is most likely to end up in the hospital for those identified conditions, schizophrenia, alcohol use disorder and opiate use disorder. And they do that by kind of training the model, by looking at who in the past has been hospitalized for these conditions, what characteristics did they have? And now we look at our current population and we say, oh, who has these characteristics? Okay, those are going to be the most likely to be hospitalized. And so what we do, we run this analysis. We update it every month with new information. Again, some of the biggest drivers, as you can imagine, are things like hospitalizations, visits, ambulance rides, but even things like metabolic disorders, because they're really closely correlated to schizophrenia diagnoses. So it's not just mental health related. It's a few different factors. And then our team generates a list, and we sort it by each state that we're located in. And we get a sense of like who would be a good fit, because otherwise they would have a higher likelihood of being hospitalized. And then once we have that list, okay, now we can go through it and see who's already involved in our programs, who's not, who do we need to reach out to. So that's probably the largest bucket. And then Cityblock also has a transitions of care team. So we are working with people that are discharged from the hospital. And as you can imagine, that's also a good avenue to find folks that could utilize these services. And so we're calling, hospital care managers, we're calling the patient when they discharge. That's another avenue for them to get engaged in our services. And then finally, our team, and I didn't go into a lot of detail, but community health partners are a big piece of the Cityblock care team. And they are, as part of their day-to-day work, they're checking in with our high needs members pretty often, at least once a month. And in the course of their conversation, if they find that there is a acute behavioral health need that meets certain criteria, they will flag that to the behavioral health team. There's a workflow that says, please review for advanced behavioral health program. And that's another avenue for a member to get flagged for this program.
Awesome. And so does a member need to have a formal diagnosis to be included, or is it just those risk factors that makes them available to it?
That's a terrific question. They do not need a formal diagnosis. In fact, we have a training for all new employees, all member-facing employees, that gives an overview of the Advanced Behavioral Health Program. And I run it. So I ran it like a couple of days ago. And in it, we go through the signs and symptoms of schizophrenia and substance use disorders in a rather non-clinical way, so that, and we make I tell everyone, if you run into someone that fits these criteria, please flag them for the program. So no, they do not need a prior diagnosis.
Awesome. One of the things that you've already said that I'm really enjoying is that that Cityblock has different types of interdisciplinary teams where each member has a different scope and a different way to look at things. And one of those team members that you just mentioned, the community health partners, can you walk us through the role of those individuals and how they differ from maybe a traditional clinical provider or case manager in supporting patients?
Yes, absolutely. That is one of my favorite roles at Cityblock. I think they just add so much to the team. So community health partners are not clinicians. They don't have a clinical license. So, they're not nurses or social workers. However, they do have close ties to the community in terms of, their day-to-day. They need to be highly organized. They're sort of the conduit for our members to meet with the Cityblock providers or even external providers. They provide that engagement, the rapport, the trust building. That's a word that we use a lot at Cityblock, trust, because a lot of our members, and the majority are Medicaid or dual eligible for Medicaid and Medicare, they do not, appropriately do not have a lot of trust in the healthcare system. And so while they might be struggling with a variety of conditions, they don't think about calling their physician in the way that, I might think about calling a physician. So what our community health partners do is they really build engagement. They try to introduce Cityblock in a way that's more appealing. They really try to understand the entire picture of the member. And sometimes healthcare is not their first or second or third priority, right? Because they might be struggling with housing. That's a big one, housing or food or legal issues. And so the community health partner is really our expert on some of those other social determinants of health. and can lead the way into that bridge between the provider and the member.
Awesome. Awesome. As you were mentioning that, the first thing that came to mind was definitely social determinants of health, because I am currently a social worker in a dialysis center. And a lot of my patients don't always come to care because they have all of these other things that are happening, and they need someone to kind of navigate that process to help them find the resources in the community. So it really seems like the community health partners are awesome at being able to, assess the needs and then being able to connect them to what is available in the area. So in your opinion, what qualities make an exceptional CHP, and how do you ensure that they're equipped to handle the complexities of this type of work? As somebody who does something like this, it can be very difficult to manage and, like you mentioned, organize all of the things that every patient or every member needs.
Oh, yes. Great question. So organization, I think, is the number one skill, to be honest. And you said it and I said it, because they're managing a panel. The community health partners that work on the advanced behavioral health program are managing a panel of 50 members. And that's a lot of members to keep track of. So organization is really key. Now, Cityblock has built out tools that surface to them, when a member needs a check-in call because if their last call was a certain days, before, or when a member needs to be case conferenced, when a member's medication might be due. But really, they need to be able to really stay on top of that workflow and be able to stay organized. So that's a big piece of it. Then community involvement, knowledge of the community is a huge one, because the trust, I can't overstate how important that is. So being able to relate to the community and the members that we're working with, having empathy for their situation, having a lot of patience. So organization, patience, knowledge of the community. Obviously, navigating the healthcare system, that's a skill in itself. But I think that piece of it, you can almost learn, as you get here, if you have the other qualities, persistence, not getting easily frustrated, as we know.
Yeah.
Things like organizing transportation to appointments, to, finding a provider that meets their needs, that has an available appointment, being an advocate for them if they are looking for housing. I know, we had quite a few instances where Cityblock itself, we don't provide housing, but we do advocate strongly for our members and help them to fill out, if they need a provider's form to be filled out for an agency, we can do something like that. And we can also just advocate for them to make sure that they stay kind of at the top of that list.
Awesome. Awesome. Okay. And a little bit ago, you mentioned training, and you actually had just done a training, right? Can you talk to me about what the training looks like and, helping to provide behavioral health support as patients navigate the complex needs that we've, just been really discussing? Because some of that does take, just innate skill, some of those qualities to do case management and that type of thing. But what about the type of training to ensure that not just the CHPs, but maybe even other people on your teams are able to help your patients?
Yeah, that's a great point. We do a lot of different types of trainings, and that I think is super important, especially when you're working with individuals that maybe are not clinical or less clinical.
Yeah.
So again, as I was saying, the basic training is an overview of the advanced behavioral health program, and every member facing employee gets something like that. And it goes through who the program is meant for, what are the interventions in the program, what are the signs and symptoms of the conditions that we manage, schizophrenia, alcohol, and opiate use disorders. And then so that's sort of the general, because we want everyone to be able to identify appropriate members for the program.
Mm-hmm.
And then for the staff that are particularly working in the program, we call them behavioral health CHPs, CHPs for short. For them, there's a lot more extensive training. A lot of it is shadowing. So we rely a lot on shadowing other CHPs that have been really successful in their role. And we have a whole program designed to shadow. We have behavioral health managers in each of our markets, and they are clinical social workers. And they typically will supervise the employees, so the behavioral health community health partners. And so they have an opportunity to sort of learn from our social workers in each market. They have, it depends on the market, but some of them have hour-long trainings once a week where they talk about, different topics. So motivational interviewing, stages of change, medications for schizophrenia. So, we do it a little bit differently, but there's a lot of training. There's a lot of people that they can lean on, clinical folks that they can lean on for support. And, again, medications is a big piece of this. And even for some of our social workers and our RNs, they may not be as familiar with the psychiatric medications. So we do a pretty extensive training on what are long-acting injectable antipsychotics and what are the main, brands, and how do you use our tracker that tracks, when someone last got their injection, what does it mean when their due date's coming up? So we try to build a lot of tools that make it easier to do the work and then provide a lot of training. But it does require constant training and reinforcement.
Absolutely. It's a ever growing, ever changing field. And so I know that level of training and keeping up with what is the latest news has got to be important in keeping things going. A little bit ago, you mentioned trust and engagement, and really the CHPs being able to develop a great rapport with patients, with members. As I mentioned before, I am a social worker as well, and been, in the community for about 15 years or so. And just being able to create relationships has been probably the most impactful thing in my career. Just being able to create a relationship with someone that may not look like me, someone that may not have been from the same area or whatever, just being able to create and foster that type of relationship, that rapport. So how are CHPs building strong relationships with patients who may be hesitant to seek care?
It's a great question. And that really is the secret sauce in some ways. They do it far better than I would be able to do it myself. Just the knack that they have for people feeling comfortable with them. I'm honestly amazed by it. There are a few people I say, wow, how do you engage these people that have not had care for years?
Mhm.
So we really need someone on here to address that. I've seen, in-person work being really important. We call it kind of feet on the street, but especially for our members with high behavioral health needs, maybe paranoia, the phone visit doesn't work too well until they've
Right.
already developed some trust. And
Mhm.
so the in-person visits are just really, really helpful. And what we end up doing is once they have that in-person cadence, and then the member needs to see a psychiatrist, then we can do a virtual visit where the VHCHP goes out there and brings their laptop, and then we do a virtual visit that way. But that's been really good. And then starting with what the member needs first, it sounds again pretty cliche, but I've seen our BHCHPs bring food, like pick up food on the way to the member's home,
Mhm.
set up grocery deliveries, set up other meal delivery systems for those who qualify. So really focusing on what they need first. If it's housing, then just being open to discussing that first before diving into any behavioral health needs, I think definitely makes it more successful.
We'll be right back after a word from our sponsor.
Are you preparing for a licensure exam in psychology, social work, marriage and family therapy, counseling, or behavioral analysis? AATBS is here to help. We have been supporting behavioral and mental health students to prepare for their licensure exams for more than 45 years, working with over 1 million students to succeed on test day and move on to the next step in their career. With products ranging from comprehensive courses to quiz banks and delivered live online, self-study online, and in print, AATBS has test prep solutions that meet every student's needs and learning styles. Visit us today at aatbs.com. That's aatbs.com, and use promo code BHT15 to save 15% off your next purchase.
Absolutely. I completely agree with you. And I was smiling pretty hard here when you mentioned bringing food over. That is one, I used to be in the school system and did a lot of home visiting. And that was one of the things that I always did. People were like, why are you taking bags of groceries? Because people want, like, if I'm bringing you something, you are more apt to first to allow that, like, wow, she actually cares about me. But then on top of that, it will allow you to open yourself up to even more assistance because you know that I actually care. So that's great to hear that strategy is kind of used in other areas as well.
Yeah, it definitely is. I actually did a home visit once with one of the CHPs, and that was one of the things that was most striking to me.
Mhm.
Before going there, we're like, oh, we're just going to make a quick stop here. And we stopped at a food pantry and they had fresh
Mhm.
food too. And so we brought
Yeah,
some fresh vegetables. We brought it over. Yeah, it definitely helps
it does.
build that engagement.
Absolutely. Opens those doors again to creating those strong relationships. It is the power of a relationship is something that is often understated. So it is really refreshing to hear that City Block focuses on creating those relationships and then using those to empower positive change with your members.
We try.
Yeah. It's awesome. It's awesome. It's good to hear. So, what role, again, we've been speaking a bit about social support, such as housing, employment, maybe even community resources. Do you feel like that plays maybe the hugest or the biggest part of success in the program, or what would you say is the most successful thing?
I'd say a couple different things, really a couple different things. Yes, I think social supports is huge. Food is huge. Housing, if we can help with housing, I've seen lives turned around, as I'm sure you have too, when someone is able to get housing and,
Hmm.
you know, medications, I will say is actually a pretty big piece of it too. What we find is that our members, especially, those who really have schizophrenia and are not adherent to medications, do tend to end up in the hospital quite pretty often. And so being able to access medications in a way that works for them has been really helpful too. And when I say that, I mean, if someone doesn't make it to their appointments or they don't make it to the pharmacy, we'll come to them. So again, we talked about those virtual visits, and so we can
Hmm.
have someone come out and bring the iPad over or the laptop over to do that virtual visit. We actually have a whole group at Cityblock called MIC, Mobile Integrated Care. These are our team of paramedics and sometimes RNs, and they will go do things like a long-acting injectable antipsychotic in the member's home if they have a hard time coming into the hub for an appointment. So we've seen that to be pretty successful with some of our more acute members who, for a variety of reasons, had a hard time taking an oral medication every day. Yeah, there's some of these long-acting injectable antipsychotics that last. So most of them last 30 days, but some of them will last 3 months. There's one in Vega Hafira that lasts 6 months. And
Wow.
so we've, when there's some members that are really, really hard to find and quite transient, we've tried that, and that seems to work really well because all of a sudden you're taking the medication twice a year.
Okay.
So that's
Mm.
been a piece of it. On the substance side, we talked a lot about schizophrenia, but on the substance use disorder side, there's also medications that are pretty effective, things like Suboxone for opiate use disorder, naltrexone for alcohol use disorder, that have been shown to really cut back on folks' use. And even from a harm reduction point of view, right? We still have people that are using it and they're maybe still drinking alcohol, but they're drinking less, or it's helping them to stay out of the hospital after drinking. Suboxone, in fact, does really, because it reduces the pleasurable sensation from taking an opioid, it really helps people to stop using that, for people to stop using opiates. So I would say the medications, have been a pretty big component of this as well.
Awesome, awesome. And when you speak about medications and the injectables and the mobile care units, so those are the reasons or the things that go into reducing hospitalizations, what I'm understanding. Can you talk about what the percentage looks like for hospital reductions and what you think that impact is like on the patients and maybe even the people that work with them too?
Yeah, absolutely. So we did do a study on one of our populations that had been enrolled in this program for about 10 months. And we're able to compare them to a control group of folks that had similar diagnoses and similar types of utilization that were not enrolled in the program. And so when we just looked at those two groups, we did find that the folks that were enrolled in the advanced behavioral health program did show a 20% reduction in inpatient utilization,
Wow.
which was fantastic. And a lot of that was due to increases in the long-acting injectables, increase in medication-assisted treatment. Those are the medications for alcohol and opiate use.
Mhm.
And so those were, two things that we saw. Also, you've got to think that it's because of just the attention that they're getting from their community health partner, calling
Absolutely.
them, sometimes on a weekly basis, going out to
Mhm.
check on them, making sure they're making it to their appointments, that their medications are arriving on time, that they are stocked with food. all of those things, right? Unfortunately, we couldn't quite break down the amount each of them contributed to that result, but you've got to think that all of that adds up to that reduction in going to the hospital. In fact, I mean, we'd have members that say they went because they were hungry, they were tired, they didn't have anywhere to go, and so just being able to help with some of those things led to the reductions as well.
That is awesome. And at the beginning, you mentioned that, it sounded a bit cliche, but this is holistic, wraparound kind of care. But I mean, it truly sounds like it is. It sounds like it is amazing experience for not just the members or the patients that are in the program, but also those that interact with them as well. As somebody who does similar types of work, not necessarily same population, but similar type of work, it really does bring a sense of joy to watch your patients go from not having much and just struggling to make it to be like you have been able to help them make their life better and reduce time in the hospital. It's amazing.
It really is. And, I think you were asking too about the providers and how they are impacted. And I have heard a lot of great feedback on these behavioral health CHPs from providers and how helpful it makes their lives. So, for example, if a member is due for medication, the prescriber, the psychiatrist, doesn't have to worry about the member getting the medication because they know the community health partner is there to help facilitate that. So that's been huge. And then once a member graduates from the program, the goal is that they are engaged in a community provider. And so part of that process, the community health partners do as well. And they help find, once the member is stabilized, they're on a medication, they've got some of their other needs met, they will then help them get connected to someone else in the community. And so our providers, I think, find that to really reduce their burden of figuring out, where is the member going to go for this or where is the member going to go for that.
Awesome. Glad to hear that.
Yeah.
So switching gears just slightly, how does Cityblock's value-based financial model, how does it allow for this holistic approach? Because it does sound so different than many other, service provider types of programs and behavioral healthcare programs. How are you guys able to do it, especially compared to, like I said, traditional fee-for-service systems?
I was wondering when we were going to go there. That is really important. That's a really important thing to talk about. So Cityblock's financial structure, we are value-based. What that essentially means is that we are pretty much responsible for the total healthcare costs of our population. We're paid on a per member per month basis to cover all their healthcare costs. We have the flexibility and the privilege of allocating that PMPM to physical health, mental health, social care, right? So everything the member gets comes out of that one payment. Now, typically in a fee-for-service model, the reimbursement rates are really different. So sometimes physical health providers, the reimbursement rate will be much higher than something like a social work or a community health partner. A lot of times, community health partner services are not even covered. And so they don't have a lot of bandwidth. Even if a group practice has one or two community health partners, they're not able to do a whole lot because the reimbursement's not there. Because we have the flexibility to allocate the funds, we're able to spend a disproportionate share on mental health and social care because we know that social needs and behavioral health needs end up driving a lot of physical health needs, right? But if you look at it, the physical health needs are, so even someone with high behavioral health needs, they're going to have the largest percentage of their spend is going to be physical health. It's going to be a hospitalization for maybe an infection or hypertension, right? However, the root cause of that could be related to their behavioral health condition. So if you're able to treat that condition or a social condition, right? If you're not housed, if you're transient, but that's not going to get compensated in fee-for-service. The housing placement or the psychiatry visit, which is extremely difficult to find in the community, is not going to be accessible, even though that's driving a big piece of the cost. So since we know that, we're able to prioritize, all right, let's spend more money than typical on behavioral health and on social care.
Very nice. Very nice. Okay. And so, and honestly, I don't think we talked about this. What states is Cityblock available in?
Yeah, great question. So we're in New York. We started in New York. We are now in Massachusetts. We're in North Carolina. We're in Florida. We're in Ohio, Indiana, Illinois, and Michigan.
Oh wow. Okay, nice. You're in my state. I'm in North Carolina. Okay. So what challenges then? It seems like there has been some expansion, but what challenges are there in expanding even further? Expanding this model to new locations, and are there ways to refine and improve those types of outcomes?
Yeah, good question. So we are, like you said, we are expanding in terms of what limitations are. Before we enter a new market, we need to contract with the health plans in those markets. And again, those are predominantly the health plans that work with Medicaid members or dual eligible members. And so that process honestly does take some time because we're not a straightforward fee for service model, because we have that value-based component. Those contract negotiations, so I'm not directly involved with, but from what I see, takes a pretty long period of time. A lot of work because the health plans themselves are probably not used to creating contracts like this. And anytime you do something that's like a little different from status quo, a lot of parties need to get involved and discuss things. And so I think that contracting piece is probably what takes the longest. And of course, the health plans need to have enough resources to be able to do that work, right? That's that
Right.
non-standard contracting, and then be able to make sure that they can evaluate Cityblock properly. It's a little bit of a project for them.
Absolutely, absolutely. And I'm with you, not necessarily on the contracting end, but I work, with a lot of patients who do have Medicare and Medicaid, they're duly eligible, and just trying to figure out which services are available and connect them to the right thing. Just that end of it is a whole job in itself. So I'm sure trying to add a value-based program like you guys that is revolutionizing things, it probably does take quite some time to do.
Yeah. I would agree.
Yeah.
But look, obviously we are happy to move and expand, and a lot of the programs have seen good results. So I think we're ready, but it does take time to contract. And then once we contract, we'll hire up. And if we're in a market already, it's easier. But if it's a new market, then we need to hire the care team, right? The
Right.
providers, the
Mhm.
nurses, the social workers, like everyone.
Right.
So that could take a little bit of time as well, but nothing, things that we'd obviously be very excited to do.
Nice, nice. So we'll continue as we're looking ahead. What's next for City Block's advanced behavioral health program? And how do you see this model evolving in the future?
Yeah, wonderful question. So the program itself now has been around for 3 years or so, maybe a little over 3 years. In terms of refining it, there's a few things we're doing. We talked about that machine learning algorithm and identifying the right members. So we're continuously trying to refine that to make sure we're finding the most appropriate members, because every so often we're still finding people that, oh, we didn't catch this person, we didn't catch this person. So we're continuing to refine that algorithm. In terms of the interventions, I mean, the interventions are pretty solid. So we feel pretty good about that. I think in that regards, it's really about just growing it to new markets that we enter, training staff, training the rest of the market, making sure that we're really integrating with the primary care system as well. I think that's probably another opportunity. So Cityblock itself has physical health primary care providers. Sometimes the members have external primary care providers. And so being able to form more collaborative relationships with their primary care providers, I think, is another goal of ours coming up. And just, continuing to build bridges with hospital systems where our members get admitted so that we're able to help with the discharge planning. That's also a current goal as well in this program.
So as we're wrapping up, Ruby, where can listeners learn more about City Block and the advanced behavioral health program and any expansion going on in those states you're already in?
Yeah, absolutely. I think a great place to start would be our website, cityblock.com website. And then I would encourage people to also follow Cityblock on social media. Our LinkedIn site is pretty active.
Awesome. I'll have to check it out myself. Thank you. And thank you, Ruby. I've really appreciated speaking with you today.
I really appreciated speaking with you as well. Thank you so much.
And thank you to our listeners for taking the time to join us. Don't forget to follow us on our social media at Instagram, TikTok, LinkedIn, and even on YouTube at Behavioral Health Today. And if you like our show, give us 5 stars and leave us a review. That helps our show get discovered and share the valuable insights in each episode. As always, the resources for this episode and an archive of all of our other episodes can be found on our webpage at triadhq.com/BHT. And we look forward to having you back with us next time on Behavioral Health Today.
We appreciate all the support from our community, and if you like our show, one of the best ways you can support it is by giving us a 5-star rating and leaving a review. Behavioral Health Today is a podcast part of the Triad Behavioral Health Network, all rights reserved.